Hello, my name's Mel. I'm one of the orthopaedic physiotherapists at Ashford Hospital.
Hi, my name is Kate. I'm the Nurse Unit Manager of the Orthopaedic Ward.
This short video will outline information and exercises to help prepare you for your total hip replacement surgery. Please remember that the information contained in this video is general advice only. There are several different approaches performing a total hip replacement, each with different things for patients to be mindful of after the operation. Therefore, you should always follow any specific advice and instruction given to you by your surgeon. You may need a hip replacement operation when the cushioning cartilage of your hip begins to wear down. The bones of the hip joint eventually rub together, causing stiffness and pain. This sort of damage is usually caused by osteoarthritis, also known as wear and tear arthritis. But the damage can also be due to other types of arthritis or following trauma to the hip. Recovery from a hip replacement takes time and effort on your part, but by 6 months following the surgery, pain should no longer be a problem. It does not always remove 100% of the pain and discomfort, but usually relieves most of it. You should have greater mobility and a better quality of life. We would expect that many hip replacements will last up to 15 to 20 years. There are many benefits of having your hip replaced, which include relieving pain, improving mobility, in most cases lessening stiffness, restoring your leg length, therefore overall improving your quality of life and allowing you to return to activities that may have been restricted due to pain. Bones of the normal hip form a ball and socket joint. The socket is part of the pelvis bone and the ball is the upper part or head of the thigh bone, the femur. During the surgical procedure, the worn parts of the hip joint are removed and replaced with artificial surfaces. The artificial socket or acetabular cup is embedded in the pelvis bone and the shaft protruding from the stainless steel metal ball is inserted into the hollowed out thigh bone. The hip must be dislocated to allow prosthesis insertion. As with any surgery, there are risks associated with the procedure. Your surgeon will have discussed these with you in detail, but they may include dislocation of your artificial hip, perceived leg length discrepancy, superficial infection, deep infection, stiff hip joint, deep vein thrombosis, pulmonary embolus, numbness around the surgical incision. The artificial joint may wear out and loosen, which would require revision surgery in the future. As previously stated, the insertion of your hip replacement involves dislocation of your original hip by the surgeon, making it at risk of future dislocation, particularly in the first 6 weeks after your surgery. There are different surgical approaches that use different dislocating forces and therefore have different precautions. Your surgeon will discuss with you your particular surgery and we can advise you after your operation. Generally speaking, most hip replacements are done via a posterior or lateral approach. If your surgery involves one of these approaches, the following precautions apply to reduce your risk of dislocation after the operation. Do not cross your legs when you're lying, sitting or standing. Do not pivot on your operated leg and avoid bending more than 90 degrees at the hip. That is, when you are seated, your knee shouldn't lift higher than the level of your hip. Most surgeons recommend you sleep on your back for 6 weeks with a pillow between your knees. We will discuss any variations to these precautions that are relevant to your surgery.
Now that your surgery is scheduled, we can commence gathering your medical information. You will receive a phone call from the nurse at the hospital or doctor's rooms regarding your medical history, social history, and any medication you may be taking. We will discuss any preoperative testing that may be required, including blood tests and anaesthetic reviews. This is an opportunity to ask questions. Closer to your admission to hospital, you will be given an admission time to present to reception. You will be given a fasting time. This means nothing to eat or drink. Please refrain from smoking or chewing gum. On your day of admission, please bring all your medications in their original boxes, recent applicable x-rays if you have them, any medical equipment you use, e.g. CPAP machine and insulin pumps, and no money or valuables. If this is a requirement of your admission, please ask for them to be locked in the hospital safe. Your clothing and nightwear should include loose-fitting, comfortable garments. We encourage you to dress in day clothes from the second day after surgery. Shorts, t-shirts, skirts are appropriate. Good fitting shoes and/or slippers with heel support, no thongs, and personal toiletries. You will be taken to day ward where a nurse will complete your admission. You will change into a hospital gown. Your belongings will be locked away and delivered to your post-operative ward on your return from theatre. You may see your anaesthetist in day ward or in the theatre area before surgery. When theatre is ready for you, you will be taken to the theatre area. Your name and personal details will be checked. Waiting in theatre holding bay is routine and gives your anaesthetist and surgeon an opportunity to see you just prior to your operation if necessary. Your anaesthetist will discuss the best type of anaesthetic for you: general anaesthetic, spinal anaesthetic, or regional nerve block. Please be aware if you do have a block that following your surgery you will notice your operated leg is numb and won't move. This is normal in patients who have had a nerve block or who have had a local block in theatre. Normal sensation and movement in your limb will return. On the completion of your surgery, you will be cared for in the recovery unit. This is where you will wake up and your pain managed prior to returning to your ward. Some patients may spend the first 24 hours in the critical care unit for closer observation. This is determined by your anaesthetist. You may have an oxygen mask over your mouth and nose. You will have a drip in your arm. You may have a drain coming from your wound. You may have a urinary catheter. You will have compression stockings on and inflatable sleeves around your legs, promoting blood flow and preventing blood clots. We encourage you to pump your feet regularly if able to assist in blood flow and to do regular deep breathing and coughing to keep your chest clear. Following your surgery, you will have pain. It is important to take regular pain relief to remain comfortable. Your nurse is there to help you decide and offer guidance as to the pain relief you may need. You will have access to different forms of pain relief. We encourage regular ice packs, regular simple analgesics, for example paracetamol, and narcotics if required. As pain is greater on movement, you should assess your requirement for analgesia based on when you mobilise. I also suggest timing your analgesia before physiotherapy visits, as this will help you get more out of these sessions. Your nurse will give you your usual medications, which we will have locked away. Please be proactive in asking for pain relief. We want you to be comfortable. You will be assisted with your hygiene needs, with mobility, sitting out of bed, and going for walks. Each day, you will be visited by one of the orthopaedic physiotherapists. In the next section, Mel will talk with you about physiotherapy visits on the ward and your exercises and expected progression throughout your hospital stay.
Our aim is to assist you to become safe, independent, and get back to an active lifestyle. It is important to remember that people progress at their own rate, depending on many factors, but the majority of people are safe to discharge 3 to 4 days after their surgery. As mentioned already, pain relief is very important. You need to be comfortable enough to move and participate in therapy to gain the best outcome from your surgery. Generally speaking, people progress through the following stages after their surgery. Depending on your surgeon's preference, we may assist you to stand up and take a few steps on the day of your operation, as long as you are medically well. The day after your operation, you will be assisted to get out of bed, walk with a frame, and sit in the chair. It is important to note that you will sometimes have some attachments, for example a wound drain, a urinary catheter or an IV pole. These things do not stop you from walking or getting out of bed. Over the next 2 to 3 days, we'll be aiming to improve your walking and we will advise you when you are safe to become more independent on the ward. We'll be aiming to increase the distance that you are walking each day. Once you are safe walking with a frame, we will aim to assist you to start walking with 1 to 2 sticks. Before you go home, you'll be shown how to safely negotiate a step or stairs. After completing this safely, you are ready to be discharged from hospital if you are medically stable. As mentioned previously, you will be in hospital for a total of 3 to 4 days after your operation. In addition to walking, you will be provided with some exercises that aim to assist your recovery. Please note that some surgeons have their own preference with respect to exercise. This will be discussed with you if relevant. It is important that you practice each exercise. It is normal to feel some discomfort during and after completing these. By working hard and practicing regularly, most people are able to regain good movement and strength. We will advise you regarding the use of ice and the timing of pain relief to allow you to perform your exercises effectively. We generally encourage people to practice the exercises between 3 to 5 times per day. We will provide you with a sheet that outlines these. We will now go through the exercises. You may like to practice yourself as we go through them. The first exercise is the foot and ankle exercise, where you should pump your feet backwards and forwards. You should perform these exercises on both feet and aim to start as soon as you remember when you wake up following your operation. This helps to get your circulation going and to prevent blood clots from forming. Aim to do at least 10 pumps of both feet every hour that you are resting during the day. The next 5 exercises should be practiced when you are lying on your bed. Practice gently bending the knee of your operated leg by sliding your foot along the bed towards your bottom. You may use your hands to help with this exercise. A mild stretch in your hip is normal. To complete the static quadriceps exercise, tighten the muscles on the top of your thigh by pushing your knee down into the bed. Keep your knee as flat as possible and hold for 3 to 5 seconds. And then relax. To practice the static gluteal exercises, squeeze your buttocks together and hold for 3 to 5 seconds. Next, roll up a towel and place the roll underneath your knee so your knee is resting on the towel. Straighten your knee and lift your foot off the bed while keeping the back of your knee on the towel. Hold for 5 seconds and then gently lower your foot back to the bed. Remove the towel at the end of the exercise and avoid resting for prolonged periods with the towel under your knee. It may be comfortable but can cause tightness at the back of your knee and also restrict blood flow. The next exercise involves bending both of your knees slightly while digging your heels and elbows into the bed. Squeeze your buttocks together and try to lift your bottom off the bed. Hold for 3 to 5 seconds, then slowly lower your bottom back onto the bed. The last exercise should be practiced when you are standing up. Hold on to a firm surface for support, such as a handrail. Ensure you are standing up tall so your legs and body are in a straight line. Next, move your operated leg out to the side, away from your body. Make sure you keep your toes pointed forwards and don't lean your trunk to the side. Hold for 3 to 5 seconds, then slowly lower your leg back to the ground. It is a good idea to have a go at the exercises before the operation so they are familiar to you.
You may be seen by one of our discharge planners during your hospital admission. Your admission with us is a coordinated, individualised approach involving you and the treating team. This will ensure a safe and timely discharge. Generally, patients discharge directly home. However, if you require assistance on discharge, this will be discussed with you and your treating team. In order to plan your safe discharge, we will ask questions about your home environment and support. This is so we can advise on any equipment you may require. It also allows us to assess and practice any skills you may need to safely leave hospital. A discharge planning nurse may see you to assist with this part of your hospital stay. We would encourage you to plan ahead prior to your surgery. For example, you may wish to freeze some meals or organise assistance with any household chores, shopping or gardening. Move kitchen and food equipment to a convenient height. You will probably need some additional equipment when you leave hospital after your operation. Your physio can assist you to organise the hire of equipment required. For example, frame, sticks, toilet seat raiser or shower chair. Please note that if you are from the country, it may be easier to organise your equipment locally before admission. Ask your orthopaedic admission nurse for advice on what you will need prior to your operation if this applies to you. You cannot drive for the first 6 to 8 weeks following your surgery. You will need to discuss this with your surgeon and car insurance provider before starting again. You may travel as a passenger, but you will need to sit in the front seat with the seat moved back as far as it will go and the backrest slightly reclined. We would encourage you to take regular breaks during your journey. Your recovery will take at least 8 to 12 weeks, and you should discuss with your surgeon before you resume work and other physical activities. We hope you've found this information helpful, and we look forward to meeting you when you have your surgery.